down mechanically with our teeth. And when we swallow, the food bolus goes into the esophagus and it passes through the esophagus via peristalsis. From the esophagus, it goes down into the stomach and begins being chemically broken down by the stomach juices. This turns the food into a substance known as chyme. From the stomach, the food moves into the pylorus, which marks the beginning of the small intestine. The small intestine consists of the duodenum, the jejunum, and the ileum, and this is where all or most of the nutrient absorption happens. So in the small intestine, we absorb all of our vitamins, electrolytes, carbohydrates, proteins, and fats. At the end of the small intestine is the ileocecal valve, and that's where the small intestine transitions into the large intestine. The large intestine consists of the ascending colon, the transverse colon, the descending colon, the sigmoid colon, and the rectum. It has many purposes also, but the main function is water absorption. So the large intestine can absorb anywhere from 1.5 to 6 liters of water per day. The liver has an amazing function that it contributes to the body. So it filters out 1/4 of our daily cardiac output by removing toxins and destroying debris and filtering the blood. The gallbladder is attached to the liver, and it's mainly a storage system for bile. And bile aids in digestion by breaking down fat. The pancreas is another accessory organ of the digestive system. It's another amazing organ. It's an exocrine and endocrine gland. It secretes insulin, and it also secretes pancreatic enzymes and bicarbonate to aid in digestion of our food. So as we age, a lot of these organs undergo many changes, and some of the complications are more just bothersome than debilitating to patients. In the mouth, we may lose some teeth. We also have a decrease in saliva and increased viscosity of the mucus. We also have a decreased sense of taste. So this can lead to a lot of the geriatric population having poor nutrition. In the esophagus, there's impaired relaxation of the lower esophageal sphincter, which can lead to GERD, which is reflux. It's what we all know it as. And also when there's problems with the upper esophageal sphincter and the lining of the musculature lining of the esophagus, it can lead to dysphagia. In the stomach, there's an increased risk for gastritis secondary to thinner mucous membrane, leading to decreased mucus production. In the small intestine, the mucosa atrophies, leading to decreased enzyme secretion and decreased ability to absorb nutrients, which again is going to contribute to poor nutrition for the geriatric population. In the large intestine, the mucosa atrophies, which can lead to diverticulosis. The liver does decrease in size, but the function is not known to alter or change based on this physical change of the liver. In the pancreas, the secretory cells decrease, which alters the absorption of fat. So as I said, in the esophagus, one of the complications is dysphagia, and this is usually related to normal changes in saliva production and reduced strength in the upper esophageal sphincter. Other causes can be a stroke or Parkinson's disease. Achalasia is another type of dysphagia that can affect the geriatric population. And we all know that in healthcare that one of the main implications of dysphagia is risk of aspiration. So this can be a big problem for the geriatric population. It can be treated with dilation, and a lot of patients see very good results from dilation, although they might need to be dilated more than one time. Another complication is GI bleeding. A lot of populations are at risk for GI bleeding, but that risk goes up as we age. One of the types of GI bleeding is called an arteriovenous malformation. And another type could be peptic ulcer disease or a bleeding ulcer from NSAID or aspirin use. Also, patients can get diverticular bleeds. That's where they have outpouching of tissue in their colon, and that there can be a bleed within that area, and that would have to be treated. So another complication would be diverticulitis. That's where small herniations in the mucosa get impacted with stool, which causes inflammation and can lead to infection. Another complication we'll touch on is GERD. It's from decreased lower esophageal compliance. It can also be caused by a hiatal hernia, and it can cause severe esophagitis and strictures. There are many treatments, too many to mention, but some of the main ones are proton pump inhibitors, strata endoscopy procedures, surgery for hiatal hernias, or Nissen fundoplications. One complication of GERD is Barrett's esophagus. It's where there are changes in the tissue of the esophagus. It mimics stomach tissue, and the body does that as a protective mechanism to protect the esophagus from damage of the acid. And Barrett's esophagus is benign, but it can lead to esophageal cancer. So it's very important for patients with GERD to be screened regularly. And there are treatments for Barrett's esophagus. One of the most common ones is radiofrequency ablation, and it's done via endoscopy. Another complication that many of us are familiar with when it comes to the geriatric population is constipation. It occurs when too little fiber is taken in the diet, and also when too little water is taken in, which many times in the geriatric population is the case. It happens more commonly in the elderly, secondary to diabetes, decreased physical activity, calcium and iron supplements, opioids, calcium channel blockers, antidepressants, strokes, hypothyroidism, and Parkinson's disease. It can lead to hemorrhoids. It can also make diverticulosis worse, and it can cause diverticulosis to turn into diverticulitis when those areas become impacted with stool. So treatment is more focused on prevention, increasing fluid intake unless the patient's on fluid restriction, and also increasing fiber in the diet. It's very important for you to teach your patients that if they start on a high fiber diet, they must greatly increase the amount of water they're drinking. If they're taking in a lot of fiber and not drinking enough water, it'll actually make their constipation worse. As a second resort, if the high fiber is not working, patients can go on to a medication such as Miralax. Diarrhea or incontinence is another common geriatric population problem due to decreased muscle control and compliance. It can lead to severe dehydration, and it can also lead to the patient wanting to withdraw from social situations because of embarrassment. It can lead to skin breakdown, and the treatments would be increased fluid intake, avoiding trigger foods, and medications to decrease symptoms. Now we'll talk about colorectal cancer, which is the main focus. It's much more common in the elderly. It's increased in patients with Crohn's and colitis. The most common types are sessile serrated and tubular adenoma polyps that convert into malignant cancers. The treatment would be removal of the cancer by endoscopic mucosal resection or snaring if the polyps are small enough. And if these options are unavailable, or if the polyp is too deep into the musculature, the patient will have to have surgery. So they might not have to have a total colectomy, they may be able to have a partial colectomy, and then they would either have a loop ileostomy that might be able to be closed at a later date, or they might be able to close take out the affected area and then do an end-to-end anastomosis. So when it comes to colon cancer, one of the biggest things is teaching our patients to follow up with their physicians regularly and make sure they're getting all of the proper screenings that they should be getting, as when it comes to any kind of screening exam. But a colonoscopy is not very invasive, it's not very dangerous, and a lot of patients think it's very unpleasant because of having to take the bowel prep, but in comparison to not detecting colon cancer, it's really a pretty easy test for our patients. So patients, when they get to the age of 45, that's the current recommendation by the Cancer Society, the American Cancer Society. When they get to age 45, they should begin colon screenings if they're of average risk. If they have a family history of colon cancer, they should begin their screenings 10 years prior to when their family member, and it's usually an immediate family member like a mother or father, they should begin those 10 years prior to when they were diagnosed. So when a patient comes in for a colonoscopy, they'll take a bowel prep. They'll have to be on clear liquids the day before, and then they'll come in and the scope is inserted to the rectum. It goes through the sigmoid colon, the descending colon, the transverse colon, the ascending colon, all the way up to the cecum. As I said earlier, the ileocecal valve is where the large intestine goes into the small intestine. And sometimes physicians will insert the scope just into the terminal ileum, which is the last portion of the ileum, to complete their exam. So, and then they will slowly withdraw the scope. Ideally, it should be at least 6 minutes on withdrawing the scope, and that's to be able to take a good look and make sure the patients don't have any polyps. The amazing thing about a colonoscopy is, even though it's not a very invasive procedure, you can take out colon polyps before they turn into cancer. So it's a wonderful life-saving screening exam. So if a polyp is seen and it's relatively small or moderate size, it could potentially be removed with a cold snare. And that's where the snare is placed around the base of the polyp and it's simply just cut off. If a polyp is larger or there's a potential to bleed or it's on a big stalk, meaning that it's not attached to the mucosa but it's hanging onto a stalk, it might be, the physician might choose to remove the polyp with a hot snare polypectomy. So that's where you still use a snare, but it's connected to a cautery device, and cautery is applied as you're snaring the polyp off to prevent bleeding. The third most interesting type of removing colon polyps, and most of the time when we're removing these kind of polyps, they are cancerous polyps, and the physician can usually tell just by looking at them, are these polyps that are very large, but they're very snug to the mucosa. And as long as they're not going deep into the musculature layer, they're a candidate for what we call endoscopic mucosal resection, or EMR. So this is really neat because this could prevent a patient from having to have surgery if the physician is successful in removing the polyp. So in this procedure, the nurse will mix up whatever type of lifting agent the physician wants, because as I said, the polyp is very tight to the mucosa, so it has to be lifted away so that the physician can safely remove it. So some of these options are methylene blue mixed with saline, Elevue. There's a new product that we're using in our facility called ORISE gel. So it's a blue gel, and you want the material to be viscous because that'll keep the mucosa lifted longer. So the nurse will inject under the physician's direction the lifting agent, and once it's lifted up and the physician feels like there's a good separation between the polyp and the mucosa, you will do hot snare polypectomy until all the pieces are removed. And then a lot of times the physician will choose to do cautery around the borders just to kill any other cancerous cells and also to prevent bleeding. And then at the very end, we will take what's called a hemoclip, which is another treatment we use sometimes for GI bleeds, and we will use that hemoclip for closure of the site. So that's a really exciting procedure because it really makes the whole team feel great when you can prevent a patient from having to go have surgery to resect the cancer. So when these patients come in, they need to be educated about the importance of a proper bowel prep, because if you don't have a good bowel prep, the physician might miss polyps, and so they'll have to come back. So as far as coming back for follow-up screenings, that's just as important as coming in for the initial screening. So that will all depend on how good the bowel prep was and if the patient saw any polyps. And if the patient saw polyps, but they were just hyperplastic, benign polyps, didn't have any cancerous or precancerous cells, they won't have to come back as often. But it's all very individualized based on what the physician sees and how good the prep is and whether or not the patient has a family history or any other risk factors for getting colon cancer. So I would urge you all to educate your patients on the importance of colon cancer screening, because again, it's one of those screening tests that can really save patients' lives because it can detect cancer before it becomes cancer. So Thank you, and I hope you all enjoyed my presentation.